And good morning, everyone. Yeah, just let me emphasize what Devin said. If you have any questions, type them in the chat as you have them. I think it's usually better to talk about them in the context of the slide and probably while other people are thinking about them. So just type them in the chat. Devin will interrupt me. Don't worry. I like being interrupted. It's hard to stare at a screen or stare at a camera for 75 minutes straight and wonder if there's anyone on the other end. And so we are going to talk about H8F. This is a little about me. My name is Curt Degenfelder. I'm based in LA. I've been working with community health centers since January of 1996. I have been to a couple of health centers in Wyoming. I can't remember exactly what the name was. It was a few years ago. So slightly familiar with the state, but again, this is going to be talking about the federal grant. And also just lastly, I'm a board member of a health center, so I get to see this both from kind of the consulting side, creating the budgets, as well as the board member side of, how a health center might plan to use the money. So H8F, a large amount of money. So this grant, so the total funding through the Rescue Act was 7.6 billion. The annual health center appropriation is 5.5 billion. So we are getting more money than normally we get in a whole year, right? Just for this one grant. So this is a substantial amount of money. Probably all you know this, but just to remind, this is based on a formula from the 2019 UDS. The task is not to develop a budget, but rather to say how to spend it. And I really want to emphasize that. I think part of it is to show, to not get, so first of all, to get the money, to budget and use all of the money, and to have that benefit the bottom line, as well as spending or maybe spending priorities in the health center without, I don't want to even go as far as to say getting yourself in trouble, but without putting undue burden on the health center. Okay. So the budget and other documents are due May 31st. I should have updated the slides. It's no longer 6 weeks. I apologize. I used this from a prior presentation. That's now like 2 weeks now, or I guess 3 weeks. And to determine how we're going to spend the funds and to document projected spending, right? And we're going to get into those details. And we have to remember, until that budget is approved, we cannot draw down any of those grant funds. And we'll look at a timeline on what might be in there, in that timeline, and how we might want to position ourselves. Just also to add a little caveat that this is, we're talking strategically here on how we would spend the funds. This is not necessarily a grants management workshop. So if there are other HRSA or NAC or Wyoming Primary Care Association resources for kind of managing the grants, if you have grants management questions, you can ask. It's not necessarily my area of expertise, but I would try to address them if any questions did come up. And we are going to get into some of the CFR rules and things like that when we think about how to spend the money. But I like easy. That's my general strategy that I've learned after 25 years in community health. Set it up to do it the easy way, not the hard way, would be a general rule of thumb I've learned. So there are 6 categories of spending. Sometimes when HRSA shows, they only show 5, but the legislation comes out with 6 categories of funding: COVID vaccinations and related activities, testing, treatment, and related activities to mitigate COVID, equipment, supplies, and staffing for mobile COVID testing and vaccination, to build and sustain the healthcare workforce, to enhance healthcare services and infrastructure and outreach and education related to COVID-19. So not all 6 need to be used. From the people I have spoken to, the bulk of funds, from what I've heard thus far, are going to be spent in categories 4 and 5, i.e. the non-COVID activities, and less will be spent in 1 through 3 and 6. Now, strategically, I might not, or I would recommend not submitting 0 for COVID-related activities, right? Maybe you might say that all of your COVID, so look at the next bullet, we have 2 grant periods, right? Grants year 1 and 2. Maybe all of your COVID would be in the first year, right? So that would be 4/1/21 through 3/31/22. You know, whatever COVID activities that you have. I'm sorry, let me correct that, because we might have some other funding for COVID activities, but whatever COVID activities you plan to use in this, you know, these grant funds on, might all fall in year 1, and I think that's okay. It's hard to picture us doing a lot of COVID related activity in the period 4/1/22 through 3/31/23. And it's my understanding that Wyoming probably has less incidence and prevalence of COVID than, let's say, here in LA. So I think that might be especially true for you. So, so it's okay if it's mostly in 4 and 5, but I wouldn't put it all in 4 and 5. That's what I'm trying to say. Okay. That's my general rule of thumb, because you know, you guys know how HRSA is. You know, oh, you're not doing anything about COVID, you know, and the answer is, well, we are, but we're spelling under funds or whatever. So you just don't want to. In my experience, regulators are very, very binary, right? It either is there or it isn't there, and it's better to have something in there than to not having anything in there with an explanation, even if it happens to be a good explanation. So I would, so the other thing I'm saying is, you know, I would not hesitate to put a greater amount in year 1. Okay, so now let's think about our timeline. So I believe we got the notice of award on March 26th. The grant period begins 4/1. The budget is due 5/31. Let's say it takes them 60 days. That's often the thing they say. If we do change in scope, you're supposed to get it 60 days and give them 60 days to review. So let's say it takes 60 days. Now, it's my understanding that the budgets that were submitted for the CARES Act funding took an average of 48 days to approve. But to me, that was, I guess I'll just say bluntly, less money, and so maybe a less complex budget, and maybe could be gone through more quickly. So at least just for planning purposes, I might expect you know, it not to be approved before July 31st. And then we can draw down associated with spending. So let's look at this timeline, and I'll say a couple things here. Thing 1 is, if you can submit the budget before the 31st, you should, right? I don't know that that they have a great queuing thing at HRSA that says, oh, we're going to do what I guess the accounting term, we're going to do FIFO for this, first in, first out. But you know, perhaps if you get it in before the crush, it might be worthwhile. Now, this budget needs to be approved by the board. I know many of us have our board meetings. You know, So the board I'm on, it's always on a Tuesday, and I don't know where that falls through the end of the month, but well, I guess if today is a Tuesday and today is the 11th, that means we're going to approve ours maybe on the 25th. So we're not going to have ours before the 25th, just to be honest. But if there were a way to get it approved by the board earlier, if it's done, that might be worth it. Secondly, I don't want to be confused to say that you can't start quote unquote spending until 8/1. You can't draw down unless it's specifically for COVID until the budget is approved, right? You can't draw down, but you should. It's my understanding that you can spend the funds, and then once the budget is approved, draw down funds for that period, April 1st to whatever the date that the budget was approved, and that would be an allowable use of the funds. Okay, so thinking about our timeline, so they're not compressing the timeline, they're not whacking, I guess in this case, 4 months out of the grant. That doesn't appear how it works to me. However, if you need the cash sooner rather than later, it might be problematic in trying to get that cash sooner because we're not supposed to draw it down unless it's specifically related for COVID, right? And if you were to draw it down, there's no report that you have to submit to them that says, hey, we drew it down and it was for this COVID-related activity. But certainly I hope you're keeping good work papers, right? So this is, as anyone in finance knows, this is a period where our work papers, our work paper and administrative burden has been much greater. And I think it will continue to be great. Right, coming from not great, like good, but great will be substantial. Right, lots of compliance related to this. Here's a view of the form. So this is the SF424A, as many of you probably know, and why it's only 4 lines when we can have up to 6. I'm not entirely sure, but we put our activities there. And it appears we do the same thing for the columns here. So to go through our lines, right, our personnel, right, those are going to be salaries. Our fringe benefit is any fringe, and if you're charging personnel, and you need extra spending, charging some fringe associated with that personnel is not a bad idea, right? Travel, like how or why travel gets its own line on a budget is beyond me. And I'm not sure that I'm using federal funds for travel. I just, keep in mind, anytime we say we're using federal funds, it creates compliance requirements. Equipment, so we'll talk about equipment, and certainly this is a good opportunity to purchase equipment. Supplies, and we'll talk about this as well, but supplies includes equipment under $5,000. So that is the federal capitalization threshold. And again, an excellent opportunity to use the funds here. Contractual, we have lots of contract stuff. So this could be contracted providers, contracted testing or vaccination, could be contracted consultants. There's a lot of opportunities here. Construction, this is just my opinion, stay away from construction on this grant. There's plenty of other stuff to spend the money on. And then other is just, other expenses that don't fall in there. If you have an indirect cost rate, you can apply it here in J. So these are what are known as object class categories. And basically, we're going to put in backup to these object class categories. So let's say we put in personnel. We're going to show the positions, the FTEs, the salary, and the amount charged to the grant. If those positions, or even if you put people's names, if those change, that's okay. Our rebudgeting comes when any of these lines vary by more than 25% on the federal share, right? So that's another reason I wouldn't do travel, right? So let's say you do travel and put in $10,000, right? You know, and you only spend $5,000. You know, they could interpret. There's also another thing that says it needs to be at least $25,000 to rebudget, but I've seen them hit people for not rebudgeting for something that's more than 25%. So I wouldn't do small items. So I'm a big fan, I guess, if I had to pick. Personnel is always number one. Fringe is associated with personnel. Then I would say supplies. Then I would say equipment, because I think we need equipment. You know, this is often an opportunity to replace equipment. And then contractual, right? So, you know, other is just kind of amorphous. I mean, if you did have other expenses, you could put it in there. Construction, I don't like. Travel, I don't like. And indirect, either it applies to you or it doesn't. So if it applies to you, you can use it. If it doesn't apply to you, obviously it's not relevant. This is just kind of some of the HRSA detail on what we put in for when we're going to need the cash and that sort of thing. Not too exciting here. Okay, so we can use, as you know, we can use up to $500,000 in total for renovation. So not $5,000 per site, but $5,000 in total for the organization. In addition, I hope folks have heard this, that the project costs cannot exceed $500,000, right? So you can't say, well, I'm going to use $400,000 of program income and yeah, okay, or $200,000 of H8F, that adds up to $600,000, right? So that's not a project you can do. This is supposed to be, I guess, minor renovation. The project cannot add to square footage. That is a specific requirement, and I guess that's how HRSA distinguishes between a renovation and, I guess, construction. In addition, I'll just add that the money very specifically cannot be used for parking lots. And I know that, you know, during COVID, you know, to have social distancing or to be outside, a lot of activities moved outside of the parking lot. You know, but unfortunately, we can't use the funds for there. I always joke, the Secretary of Health and Human Services, Javier Becerra, is actually from LA. And so he should know about the importance of parking, but apparently he said, no using for parking lots. So too bad. It entails additional federal requirements. So demonstrating site control, right? So they don't want something where the lease is up next year and, you know, maybe they're gonna give you $500,000 of federal funds to renovate, and then, you know, you get kicked out 6 months later, right? Then that's not a wise expenditure of federal funds. Historic preservation, and again, the regulatory definition of historic is, I'm sure, different from yours and mine. So you just have to make sure you're not in a building that would in any way, with any construction, be considered monitoring, changing a historic building. Environmental review, what's the impact on the environment? And then a federal reversionary interest. So let's say you wanted to move out of that site in 2 years, you kind of have to get the Fed's permission because they paid for a portion of it. What you will not see on this list is Davis-Bacon, which is a requirement that you pay prevailing wages. Apparently, Davis-Bacon doesn't apply to this. So the specific capital grant funding, so we now have details on that, and I'll show that in a second, which was my guess, but it turned out to be a pretty good guess. But given the all the other potential uses of funds, as well as the fact that we're getting capital funding later, I wrote health center needs to carefully consider using H8F for renovation. I guess that's my way of saying I wouldn't use the funds for renovation. I don't like those requirements. I'm going to pause for just 1 second if anyone wants to type in something, or if you have a specific scenario, if you were planning on using the funds. And again, I don't want to debate with you, but maybe we could just kind of talk it through on what your own plans might be, and consider that.
Curt, I had a question. I had heard from another health center, I guess you could say anecdotally or whatever, that one of the appropriate uses of funds would be to like anything you use program income wise in 2020. So like anything we weren't using grant funds for, that you could take this ARPA funds and actually kind of go back and cover those program income costs in 2020. So then you kind of get that program income back that you can do a lot more with. Is that something you can speak to or give direction on? Or if that is viable, what the particulars of going back and doing that would be?
Yes, and in fact, I have a slide on that. So I can definitely get to that. That one to me is, if renovation is a red light, that one's kind of a yellow light. But we'll absolutely talk about that, because again, strategically, that might be the right move for you. So we'll get back to that when we get to that slide. Okay, so this is how they came up with the money. I reverse engineered the 6.1 grant funding. So the H8F base was $500,000 per health center. There were a total of 1,376 awardees, so that was 688 million. Then they gave $125 per patient from the 2019 UDS. So there were almost 30 million patients, so that works out to $3.7 billion. I always have to remember to put a B at the beginning. I'm not used to dealing with such large funds. Then uninsured patients, they gave 250, in addition to the insured patients. So then carve those out of, I'm sorry, they didn't carve those out of the 29 million, 6.7 million for $1.7 billion of funding. So 688,000 from the base, 5.4 from the variable, about 6.1. So I know they're giving $11 per patient on the C8F. I forget what it's called now. I wrote it down somewhere. But anyway, on the capital funding. And this is how they came up with the number. So basically, again, 688,000 of kind of, I don't want to say base funding, because that's a different term, I guess, in federal funding, but 688 just from the initial amount that everyone gets per, and then so I just took 1 billion minus 688 million is 312 million, divided that by the patients, came out with $10.46. So this will actually be, 1,140 million in total capital funding, right? But that's how they came up with that number. So I'm gonna guess for Wyoming, the number of patients is less. So I'm guessing that your capital is probably more than 1/6 of your H8F. In California, we have some giant health centers. I have a client that's getting $36 million through this. So their capital is much less than 1/6, even though it's 6.1 billion versus 1.1 billion. So just when we think about things in terms of proportions, that's how they came up with the money. Okay, so to Heritage's question on prior period, So we can charge grant costs back to January 31st, 2020. That is, keep in mind, that's not January 1st. That's January 31st. I believe that was the date of the initial, I don't want to say public, it could be public health emergency or some other thing that they said, with COVID is officially here. Cannot include costs already covered under prior federal grant funding. So this is where it gets tricky, and we can talk about the strategy. So it might be best for anyone who needs immediate cash. So again, I'm gonna say, when we go back to our timing, I'm gonna say that you could not draw down funding for prior year spending until your budget has been approved. Okay. I asked that to HRSA. They said, ask the grants management specialists. I asked one grants management specialist and they didn't know. So it's also my sense that HRSA is very overwhelmed right now. I mean, it's kind of disappointing that they don't know the answer to these questions that I don't know, pop into my head like immediately. But it's also good if you didn't get other grant funds to cover prior costs. For example, if you didn't get PPP round 2, or if you didn't get provider relief round 3, and then have very detailed prior period accounting records, maybe down to the individual person level. So I think you need to have, you need to have finished your grant accounting for that prior period, right, before you say you're going to use those funds. So we actually, on the SF 424A, I know the answer to this question now, so we actually put them in the category, but in the backup, they want you to show kind of, and we put them in year 1, so they want to show the year and prior year. And then to me, it should be used with caution. If you use more recent costs, then the better. Now, to the question of, so let me get to the first philosophical question that Heritage asked, which was, well, can I then, use program income then for other things if I'm drawing down cash? So the answer to that is yes, right? So that it's kind of the same reason I don't want to use funds on the renovation. I would rather have you use grant funds for $500,000 of allowable salary, and then with the cash freed up from using those grant funds, use that for your renovation. So absolutely. I would, so theoretically, you could go back, because I'm pretty sure you're probably not charging this to any other grant, and you could call it 4 or 5, the maintenance of work. You could charge your billing department for calendar year 2020. Well, I guess for February 1st, 2020 through 12/31, and that would be an allowable cost, and you could budget that, and then you could draw it down. Let's say in the example of our timeline, you could draw it down on August 2nd, and bam, all of a sudden you got cash. So
on those salaries though, so most of ours would be salary, or like maybe our EHR costs, like our monthly fee for our EHR. But do those have to tie back to COVID, or can it be just generalized operations? So like, that's
right. So this is where we're getting back into this now, right? So this is why I said it is my sense that a lot of this stuff is going to be in 4 and 5, right? So, so the argument for the EHR, it's a substantial part of our infrastructure, that we spend a decent amount of money on, right? And to me, EHR, so I guess some other things that tend to work are utilities. And I know EHR isn't a utility, but with a utility, you can say, hey, it's the power company, this is what they charge. Same thing with your EHR. you know, it's not like you're going out and buying it and you can competitive shop your monthly EHR fee, right? It kind of is what it is. So, and you have not previously charged your EHR to any other federal grant?
So like for ours currently, I think when we first opened, we had put it into 330, but now we've got enough salaries that our salaries utilize most of our 330. So our EHR then comes out of program income for the last like year, I think. So that's kind of how we've done it for our accounting purposes. So, and it's very clear, like like there'd be very clear dates, you know, like what would be when that 330 got spent and when it would be not spent. Is that, I don't know if I'm making sense, but
you are. If you said are you a new grantee then, or
about 5 years ago?
About 5 years. 5 years is way back far enough. And what is your fiscal year?
The calendar year.
Calendar year. Okay. Yeah, I was hoping you were June 30, so I could say, well, you could start at July 1st and then just start from there, because then you can really tie it out to a fiscal year. So I guess, right, you would have internal monthly financials, and you know, theoretically you could charge it then back to February 1st, 2020. I'd go light on this one. Do you need the cash?
It'd be, we're looking at a capital project, so it would be nice. I mean, we can definitely, it's not like so for us, like we could easily probably go one way or the other. We could either continue to buff up staffing in using the ARPA for the next 2 years and just plan that way, or being able to have it in program income with cash, so that we have the flexibility to spend it if we needed to over the course of the next 2 years in a capital sense would be nice.
And this is what I was talking about with another finance person. We're talking about, we would limit that amount to 20% of the total. We totally made that up, that amount, but you know, that's kind of, you know, below 20% often like kind of falls into miscellaneous. So I would say, you know, if you need the cash, right, not because you're low on cash, but you do have some capital expenses coming up, that might be a good way to do it, right? So again, the philosophy and the strategy of assigning expenses and drawing down the funds and the cash associated with something else, and then using that cash for capital, as opposed to budgeting for capital and then being required to have all those rules because you're using federal funds for the construction or whatever it is you're doing.
Right.
Okay. So, however, we now then have the capital funding, right? So that's use it or lose it. So you do need a project. I don't believe you have that. You're going to have the flexibility with the capital funding to say, well, we're not going to spend it on capital. We're going to spend it on salaries. I don't believe you're going to have that opportunity. So I guess save enough construction cost for that grant, if you know what I mean.
Yeah, this would be a new building, so that'd be it'd be a non-issue on that.
You're saying it would cost enough that you would have enough from both. Okay. So, and again, you might have the federal requirements then anyway on that building using that cash. And I have not yet become expert in that capital grant, but I think your strategy works, I guess I would say, you know, enough to get the project started.
Curt, there is a question in the chat as well.
Yes.
Do you want to take that now or wait? It's somewhat aligned with what we were already talking about.
Okay. Can the costs include salary costs that were in the CARE funding, but once the CARES funding is expended, the salary is then part of ARPA? We hired employees in response to COVID, so part of the CARES funding. In order to keep them on staff, we either build them into the budget at the end of CARES, or put them in year 2. You know, I always like to focus on language. So the short answer of your question is yes. That we could have individuals that were hired or retained using CARES Act funds, right? So that was the H8C or D. Then we should, so again, and I don't know if you're talking about prior period here, Margaret, but what we would do is, you know, you'd have that documentation for the spending, and let's say, you know, you had spent all the CARES Act funds by, I think they were supposed to be spent by last month, right? I'm just getting the years, the months and years straight. I believe they were supposed to have all been spent by March or April of this year. But if you spent them, I would add, if you spent them before then, and you showed that you had fully expended those funding, yes, you could begin the, you know, assignment of H8F funding to those individuals.
Thank you for that. We applied for a no-cost extension on the CARES funding, so that will go through 3/31 of 2022. So that's why we would then put it into year 2 of ARPA.
Okay. Yep. That's fine. There's nothing that says once they've been partially paid, then they can no longer be paid. This is just for that specific, you know, literally you could even say that specific payroll, right? This payroll was paid for with CARES, this next payroll was paid for with ARPA, right? So that would be totally allowable. I would not try to say, well, you know, we only charge 20% of their salary to CARES, so we're going to charge 20% to CARES and another 20% to ARPA. That is a balancing act that just scares me way too much. You know, the other thing is, I'll go back to this category. To me, you know, this infrastructure would suggest you could also charge people who we don't traditionally charge to grants. I mean, like administrative people, you know, as part of our infrastructure, could be charged to ARPA. So generally, I know we like to charge doctors and nurses and medical assistants to the grants. The ARPA seems to give us some flexibility to charge a greater number of people. And again, this is not competitive, right? Normally, if you're writing it for a competitive grant and you said, well, I'm going to use this money on a biller or, you know, an IT person, you know, that's not going to excite people for the use of fundings. However, in this one, where it's already funded and you're just being asked, then it would seem to be okay, right? And again, I'll say that make sure you are keeping good records on this spending. So, because I'm guessing that some salaries are also being charged to your base grant, right? So this is what I always tell people. Federal government will pay $500 for a hammer, but they won't pay for a $40 hammer twice. Okay. So that's my rule with federal funding. So so the answer to your question is yes, and maybe then if you got that no cost extension, maybe you would. And so I just want to be clear, just the way I envision, I like to get the cash sooner than later. Maybe your budget would be more heavily weighted to year 2, and that's okay. Okay. Jan, did you have a question, or you took yourself off
sorry.
mute? Okay.
I'm just an active participant here, Curt. Thanks.
Okay. So then I like more recent costs are better, just generally, but use that prior period with caution, because this is unusual for us, right? I don't know of any not that I, keep track of this, but any grants that we could have charged to prior periods. So I don't know what the ultimate auditing of this is going to be. I mean, it could be, it's possible that they just shoveled out so much money so quickly, and they're talking about now, another $2 trillion for childcare or whatever, that to try to audit all of this will be impossible, right? But I would definitely make sure we keep our records and, kind of document how, based on what we knew from the way this grant worked, we spent the money appropriately. Okay, so we talked about prior period, we talked about renovation. So what are a good use of funds? Certainly people, right? Salary is largest line item for every health center. It's really easy to track spending, right, on payroll, because we do our payroll, every 2 weeks or twice a month, right? As you probably know, we have a rule that says we must spend grant funds within 72 hours of drawing them down. And so we know when that payroll is. We could draw the grant funds down, the day before or even the day after payroll, right? Because you can say negative 24 hours is less than 72 hours, right? Just when you think about math. So you can certainly, you can always, within a grant period, ascribe grant funds to previous spending. So HRSA has already specifically said that the funding can be used for hero or hazard pay, and that it could be retroactive. So we're going to give people some sort of payment. It's also said that for staff salary increases that were put on hold because of COVID, but we have to have a policy. And so with the hero or hazard pay, what they like to see is the term unforeseen circumstances. So that there was some reason, some special reason I'm sorry, let me change that. Unexpected and extraordinary circumstances. So we have this policy because we had unexpected and extraordinary circumstances. So let me give you an example of what we're doing with one of my clients. So we are, they were supposed to have a raise last year of 3%. They were supposed to do a raise this year of 3%. I'll just give you some backdrop too. They have a lousy HR person, so don't ask questions of, well, that doesn't sound like it's being done correctly, Curt. They have a lousy HR person. I'll just say that. So 3% for last year, 3% for this year. So we're going to do a catch up of everyone's salary on 7/1, because they are a June 30 fiscal year. On 7/1, they're going to do a catch up to bring everyone's salary to kind of the raises they would have gotten. Now, let me just say one more thing about this. They have to kind of put together a policy on this, because a lot of times the raise is given on the employee's anniversary date or something. So they're kind of doing it this way with the explicit thing of, we want to spend the money quickly, right? And we want to get everyone a raise quickly, right? So again, this partly is because they have a lousy HR person. So it's kind of like, I can do the blunt force 6.1% on, for everyone, and everyone gets the same, as long as it, I guess, as long as it doesn't kick them out of the salary range that we have stated for that health center. Or we can try to do it your way on anniversary date, and you're going to have a lot of unhappy people who it's going to take a long time to get the money to. So that's thing one we're using the money for. Thing two is we're calling it like a retention or thank you pay, which is 3% of their salary from March. Let me think of the period. So March 1st, 2020 through February 28th, 2021, right? So thank you for sticking around, bonus, right? And then we're doing 3% funding of the 401k. So they have a 401k, but they don't have an employer match. So they are doing a one-time employer match with then the option of having the board approve a second 3% match for year 2. What we're not doing though is saying that every year we're going to give a 3% match, because I'm not sure I'm not sure they can afford that on a go forward basis once they don't have these funds. Okay, so so I don't know what it's like in Wyoming, but we're really struggling with the low end of our pay scale in health centers here in California. So so I will just say, so I was an economics major in college, and so I'll just say, not as a red or blue, but I will say that supplemental unemployment insurance tends to distort the labor market at the low end. That is a classical economic theory. And I'll tell you that we can fight about it all we want, but community health centers have told me that that has held true, right? So, you know, if we think about a lot of our staff, you know, a lot of our staff are younger and a lot of our staff have kids, right? So I don't know if school was shut down there, but it's kind of, well, I can go to work and get paid the same amount, and then I'm working and maybe being exposed to COVID, and, you know, I don't know who's watching my kids, or I can collect this, you know, enhanced unemployment insurance, right? So that certainly skewed the bottom of the market. The other thing that skewed the bottom of the market is, well, that's happened to other healthcare employers like the big hospitals and health systems, and they've jacked up their pay. So, you know, and again, I know it's more expensive to live here in California, but Sharp Health System in San Diego County is paying MAs $24 an hour, right? So that's really hard to compete with. So to me, you know, looking at that is a good use of funds. Now, the downside is, right, you know, if you raise salaries, what do you do when the grant funding ends? Right. And I don't want to say it's do it and worry about it later, but if you don't have enough staff and we can use this money for staff, maybe we even pay sign-on bonuses. So I don't know if you're paying them to providers right now, maybe we even pay them to staff, you know, for some low end. In my experience, they've got to survive at the health center for, you know, past the probationary period to get it, because we tend to have a number of people who don't, but that might be a way to use the funds as well. Okay, to rebuild. And if we go back to, excuse me, if we go back to our list, that's definitely one I could say is rebuilding the workforce, right? That we don't have enough people. Okay, some other things, practice transformation. So we've been talking about using scribes since like the beginning of time. You know, and everyone asks me, well, Curt, you know, do they make us, you know, I talk to a lot of CFOs, and CFOs want to run the cost benefit analysis. Do scribes make providers more productive? And if so, how many more visits a day are they going to do if they have a scribe? So they can do the math and say, well, if I'm paying the scribe, you know, fully loaded $25 an hour, and there's 8 hours in a day, that's $200. And if I can get 2 more visits and my net revenue per visit is $150, then I'm generating $300 of revenue for a $200 of cost. So I'll hire the scribe, right? But we don't know that that's true. And we also know that life is not as cause and effect as our CFO would hope it is, right? Sometimes things just happen one way or another, don't work the same. However, I would say that over the course of 2 years, you can analyze whether or not that works, right? So by the end of 2 years, you can say either it increased productivity or it didn't change productivity at all, or it improved the quality of our data, so it's worth it, right? So it gives you the money, in my opinion, to experiment. Or, I don't have enough MAs, right? And it's the same thing. If I gave you another MA, how many more visits a day would you do? So maybe it's to hire that second MA per provider, or I wrote third MA, not a provider should get 3 MAs, but maybe 2 providers each only have 1 MA. And so we had a third MA that they split, right? We should be able to identify that impact within 2 years, right? Whether or not it works. Active panel management, everyone keeps talking about population health. If you don't even know who your patients are, it's very hard to do population health, in my opinion. So I define panel management as every patient that we have is assigned in our EHR to a provider still employed at the health center. I know that sounds easy. It's actually quite difficult. And you could hire temps to do this or whatever you wanted to do, but that to me is active panel management. And then data and analytics. So this is a good time to maybe purchase software that sits on top of your electronic health record or accounting system, right? There are a number of packages out there. I don't know what you guys prefer, but if you're not there, there's a module you wanted or something like that. Especially, someone talked about their ongoing EHR fees. Quite honestly, especially if it's a purchase model as opposed to a subscription model, i.e., we have all the costs now as opposed to a ton of license costs in the future. That would be something worth spending the money on.
Hey, Curt, did you see that you have another question in the chat before we leave salaries?
I did not, so hold on. Does the thank you bonus need a policy associated with it? I don't think so. I think it needs some backup to say, we're doing it, and and we are, as part of the so we're making it one time as well, and as part of getting the grant budget approved by the board, we're getting this approved by the board. So to me, I think that's enough. What's in your policy already with regard to bonuses? Yeah, and sometimes it's already in there. You can pull it out. So at the health center where I am, where I'm on the board, we have something. It's kind of very vague language that says something about. It's actually not a policy. We're getting it out of the, believe it or not, employee handbook, but it talks about that you can get a bonus. So we're saying the bonus is coming under that. So, Carl, you're right that we should look and see. Many of us already have something about, like you said, discretionary. A discretionary payment. Absolutely. So COVID, obviously, we can use it for vaccinations or mobile vaccinations. Other activities for which funding is run out, so if we're doing testing or contact tracing or PPE, or bringing patients back in, right? So if we're, I don't know, doing outreach to say, okay, it's safe to come back to the health center, that would be a pretty good use of the funds, I think, right? To say, we're using it on that. And I hate to dismiss COVID, but it's kind of it's funny. I do a lot of training and people Curt, we're kind of done with COVID. Not that it's gone, but if you haven't figured COVID out by now, having a consultant explain from LA explain it to you is not going to help you too much. Okay, so telehealth. To me, and I don't know how heavy you guys have gone into telehealth, but this was our big shift, right? In March of last year, going to telehealth. So, HRSA specifically said remote monitoring devices, if you wanted to get into that, are allowable use of funds. Building infrastructure for telehealth, right? That I don't know if you need a better phone server, or if you're doing video and your system is slow, right? Then, and you need, I'm not an IT guy, you can tell, but you need to change it, then you need to add more equipment, then you can do it for that. Re-engineering telehealth, we put that in a hurry, right? And so maybe we're not doing it exactly right. So are there ways we can change it? And then transforming telephone visits to video. And Jen, I don't know if you want to speak to this, but one of my concerns is we do in community health centers a lot of stuff over the telephone, a lot of telehealth. I got to tell you, it works better than video in many, many instances, but it's really hard to convince the policymakers of that. So I have, I'm pretty sure that we're going to continue to be reimbursed for video telehealth, but I have some concerns about phone telehealth.
So Curt, I just would add quickly that within 4 days, Wyoming Medicaid agreed that during the PHE, we would, the health centers would be eligible for telephone only. And of course, we're working with NAC at the federal level to see if we can maintain that. I would leave it to the health centers to say whether that's worthwhile, but certainly during the pandemic, it was an important step.
No, and I'm not denigrating telephone at all. What I'm saying, I'm trying to look into the future. And what I'm trying to say is, I believe, so we didn't do much video either before. We're probably doing a lot more video than we were before. So we're going to continue to do video. So here's an example. I have a client using Microsoft Teams to do their video, and apparently it doesn't work very well. I'm not a clinician. So they're going to get some different video telehealth app to do video. That's kind of, re-engineering it or changing a different way to do it. But the telephone, it's just my concern that they're not going to pay it. Like CMS was hostile to telephone as well, forgetting about the states. CMS initially in their draft thing on FQHCs weren't going to pay us for telephone visits. So Medicare wasn't, I'm sorry, that's because, CMS. So it is just my concern that once the public health emergency ends, they will continue to reimburse at the PPS rate for video, but they might not for telephone. That's the concern I'm trying to express. So if there is any way to use these funds to transition more of our telephone visits to video, that might be a good use of the funds. I guess that's what I'm saying. So I see we have some chat questions. Yeah, so behavioral health, in my experience, I have clients that behavioral health is 100% telephone. So, that's a big transition, right? And, and their mental health is way up, right? And they're doing it better. But to me, that funding stream is threatened, right? I can't say, well, if they stop paying for it, just keep doing it and don't get paid for it. That's not a great business strategy. Okay. Equipment. So I'll tell the non-finance people that, like, finance people love this. So we got this at one of my clients. Now this is a larger health center. So the operations people asked all of the clinics for a wish list, right? What do you want? And this was the list. This isn't even the entire list that they got. Some of that dental equipment, wow, is it expensive? I'm not showing it here, but anyway. So, this is, I'll say, for non-finance people, this sort of thing makes finance people's lives easier. This is the way we like to see this. This is from an Excel spreadsheet. I can sort it by total. I can sort it by unit cost. I can sort it by quantity needed and say all that stuff where we only need one of. Maybe we're not going to deal with that because that's just too much hassle to figure out, why we only need one ear lavage machine or whatever. I don't, I don't know what the right way is to do it, but and then we'll also look at this list and say, I'm going to lean towards, again, all the things. I'm going to lean away from using the money on the, I don't even know how to say this, bilirubinometer, whatever that is. That's over $5,000, and that puts in more federal requirements since it's over 45, under 45 CFR Part 75, since it's over $5,000. So, I'd rather buy the 34 blood pressure auto carts, even though they cost 44,000, than the 5, whatever those things are, even though they only cost 28,000. Right? Because it puts the more rules on it. So again, when you're talking about kind of the fungibility of funds and program income to make it easier, that's how I make it easier, right? When I have to choose. Okay. So now here's a philosophical question for all of us managers. So how do staff value one-time pay, right? So if you are going to give, call it hero pay, hazard pay, retention, bonus, whatever you want, and you say it's going to be X amount, fixed amount or X percent of your salary, please, 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 when you announce it, remind your staff that it is taxable, okay? Right, so if you say, we're going to give everyone $1,000, right? You don't want them going out and spending $1,000 or thinking they're going to get $1,000 and then only get, I don't know what it works out to for get, $800, right? Or whatever the amount is. So remind them it's taxable. To increase staff at compensation. So I love the kind of bottom up working and saying, are we paying those people? My money goes a lot further, right? $1 an hour, you give a provider $1 an hour more, they're going to laugh at you. But at the low end, maybe it makes more sense. And being at or near that market rate. Oh, here's the other thing on equipment. I'm sorry, since you guys are kind of quick studies on these funds. I want to position myself so I'm not buying much equipment. Let's say from 4/1/2023 through 3/31/2024. That is, if I can buy equipment ahead of time in year 2, so I don't have to do much equipment replacement in the following 12 months, again, I've freed up all that cash I was going to spend on that equipment, right? So that to me, I don't know what useful life of equipment is or anything. Obviously, you're not going to buy equipment that you wouldn't use for a couple of years, but you can kind of buy ahead, right? Or even supplies, there's a lot of options there. Fringe, I don't know. Again, I talked about the 401k and we're doing a one-time, greater coverage of health insurance costs would be a boon to all of our employees, but I'm not sure how much recognition we get out of it. I'm trying to be, I know I sound a little cynical here, but provider recruitment and retention and maybe even staff recruitment. If I know that, again, here in California, the labor market is incredibly competitive, but I'm seeing recruitment bonuses for nurses and MAs. Not necessarily for front desk staff, even if they're kind of making around the same amount, but that's just something we're seeing. Okay, so here's my case study. People are always like, Curt, you got to put more case studies in there. And so here's my actual case study. I went to a clinic. So at the Hidden Hills Clinic, the staff expressed a dissatisfaction with the blood pressure equipment. There used to be 3 automated cuffs. 1 broke, and now there's only 2, and the staff fight over them. Now, they don't physically fight, but there's always disputes over who gets you the automated one. By the way, I just have to add the providers, as the providers said, well, what do you think of all this? And they said, well, after they check it, I check it myself manually. I don't trust any of that stuff. So just keep in mind that's going on here as well. But all of the nursing and MA staff said they could be more productive with automated cuffs. The nursing manager said when she worked at the hospital, and you guys have heard this, this equipment was standard. You guys have heard that speech a million times, I'm sure. You know, and this is in a room of like 50 people, I'm listening to this, and a new machine costs $650. So in this case, $650 could buy new equipment, maybe a potential productivity increase. I'm not sure. My visits per day at that clinic are going up. Maybe they can do it faster. That's fine. An increase in staff satisfaction, since we're not fighting over the machines, a demonstration that the management team is listening. Hey, you asked for stuff and we got it. You know, that equipment list that I showed you before, hopefully came from asking staff what they need, not, you know, just centrally, hey, we'll put this many here, this many there. And an impression that the clinic is up to date, right? All of those things I think have some value. I don't know that I can put a dollar value to it, but I feel like I'm getting a lot for my money with this $650. So one last thing, two last things actually to remind you. So one is we're gonna have to do quarterly reports. I don't know yet when they are due, but they have not put out the format yet. So I'm concerned about the third bullet. How do we, you know, so I guess it's just number, but do we have to say what we screen them for? I don't know how that's going to work. I don't know if we count that. I don't know if we record it for every patient. So if we had to report on it, we could. Number of virtual care visits, what does type mean? Is that phone versus video? They haven't defined that yet. So that concerns me. And do you have the ability to track that? And then number of enabling services patients. I guess that's kind of like Form 5 of the UDS, but we got to do it quarterly. So these things worry me, to be honest, to say, is there going to be some increased data capture and reporting out of this that we don't do currently? And we got to do it every quarter. Okay, so keep in mind on this. And then I'll just end with, I should have put this up with the telehealth section. Here is my speculation, right? And I put 2023 in case the public health emergency. So there's three variables: provider location, patient location, and modality. So if the provider is at a CHC site and the patient at a different CHC site, and we do it via video, because why would we do it via telephone? So this is if you have a specialty at one site or even behavioral health, right? You can connect. And that was something that I believe a number of health centers were doing even before the pandemic. The fact that we'll get paid at PPS, or the probability of getting PPS, is high. Provider at a CHC site, patient offsite, getting paid for video, I think is high, right? That telehealth is here to stay. CHC site, patient offsite, and I didn't put home or wherever. To me, it's very binary. Either they're at the health center or not. Medium to low, right? I worry about this one, I said before. Provider offsite, patient at CHC site. So some providers have said, you know, I have my own health concerns. I don't want to come in. By video or phone, again, to me, you kind of have an NPI here. It seems like it's high to medium. Patient offsite, provider offsite, the dual remote, I don't know. I have less confidence in this, and I have even less confidence if it's done via phone that it will get paid. So with that, I'm done. I think we have, boy, we used 73 of these 75 minutes. Are there any other questions? You can even unmute yourself if you'd like.
Well, I'll just hop in here and do a quick thank you for that information. Colette did say that she found it very helpful. As always, our need for information is never ending. So I did put a survey link in there. So please complete that. It should take about 2 to 3 minutes. But yeah, if want to thank you again. And if there's any other questions, feel free to say them right now. And oh, Jan?
Just want to remind everybody that Curt did allow us to record this, and so it will be available. I feel like this is very information packed, and so for those folks who couldn't attend or any of your staff that you would like to see this, we'll make that recording available. And I just want to thank Curt so much.
All right, not seeing any questions. We'll give back a couple minutes. But yes, hope everyone has a great rest of your day, and we'll make this available to you.
Thank you. Thanks, Curt.
Okay.